Good morning, good afternoon, and good evening. And greetings from the Prasanna School of Public Health in the Manipal Academy of Higher Education in India. It is my pleasure to welcome all of you to the second edition of the Professor Rajani Prasanna Endowment Lecture Series. We are delighted to announce that a publication called Climate Change and Public Health Governance and Challenges emerged out of the first series, which is actually giving us an extra impetus to do the second series. So the second series is starting now, and we hope to have a good series of lectures in the second series as well. Let me, as part of my welcome address, invite and also introduce most of the speakers so that the rest of the proceedings can be relatively smooth. First, let me welcome Dr. Henry Falk. He will be the chief guest of the day. Professor Falk is a seasoned public health expert with over 30 years of experience in environmental health. He has held key roles at the CDC USA, including Director of the National Center for Environmental Health and Assistant Administrator of the Agency for Toxic Substances and Disease Registry, ATSDR. Dr. Falk also serves as an adjunct professor at Emory University's Rollins School of Public Health. Next, let me introduce Mr. Nihar Prasanna, who is the guest of honor for today's function. Nihar Prasanna is an accomplished leader in corporate business development, digital strategy, and marketing, with more than 18 years of experience across different countries, primarily in the diagnostics and life sciences sectors. Currently, Mr. Nihar Prasanna serves as the Senior Director of Digital Business Strategy at Irvine, Boston, United States. Then let me welcome Dr. Vikas Kapil, who will also be the moderator for this session. Dr. Vikas Kapil is the Chief Medical Officer and Associate Director for Science at the CDC's Global Health Center. He oversees scientific quality, ethics, and integrity across its divisions and country offices. He leads research programs and health equity initiatives focusing on climate change, health systems in low-income countries, and environmental emergencies. He also serves as an adjunct faculty at the University of Cincinnati and at the Emory University. We are privileged to have Dr. Thomas Matt as one of the speakers for the lecture series today. Dr. Thomas Matt is an environmental epidemiologist and physician with more than 30 years of public health practice and research experience in government, academia, and non-governmental organizations. His work has spanned a range of urban developmental exposures that contribute to health inequities, including lead poisoning, unhealthy housing, air pollution, and climate change. As an assistant commissioner with the New York City Department of Health and Mental Hygiene, Dr. Matt led the development of the New York City Community Air Survey and the department's climate and health program. Then I am very pleased to have Dr. R. Srikanth as one of our expert speakers for this evening. Dr. Srikanth is the Dean of the School of Natural Sciences and Engineering and also heads the Energy, Environment, and Climate Change program at the National Institute of Advanced Studies, Indian Institute of Science Campus, Bengaluru. He graduated from the Indian School of Mines and was awarded the ISM Gold Medal. He has a dual PhD in Mining and Engineering and Operations Research from the Pennsylvania State University. Let me also cordially invite Dr. Dhanasree Jayaram, who is an assistant professor at the Department of Geopolitics and International Relations at Manipal Academy of Higher Education, and she will be our third speaker for today. Dr. Jayaram is an expert in climate security, environmental politics, and India's foreign policy, focusing on the intersections of climate change and international relations. Dr. Jayaram holds a PhD in geopolitics and international relations, with her research encompasses climate policy, environmental governance, and the strategic implications of climate change on national and global security. Now it is my privilege to invite Professor Dr. Sharath K. Rao, Pro Vice Chancellor of Health Sciences, who actually leads all of us and gives us the guidance and strategy to take our work forwards. We are privileged to have him for the presidential address. He is a distinguished orthopedic surgeon, but also has held various leadership roles, including the head of the Department of Orthopedics and Dean of the Kasturba Medical College. Let me now invite Dr. Sharath K. Rao to deliver his address. Sir, over to you.
Thank you, sir. Thank you very much. Good evening, good afternoon, and good morning. All the distinguished guests, faculty members, dear students and friends. It's my great honor and privilege to welcome you to the second lecture series as part of the Professor Rajani Prasanna Endowment lecture series on climate change and public health. Your presence here today reflects our shared commitment to addressing some of the most pressing challenges of our times. I would like to extend my gratitude to Professor Rajani Prasanna Endowment for their unwavering support in fostering the intellectual discourse on critical issues which are global. Professor Rajani Prasanna is a visionary educator and a relentless advocate for the knowledge that serves humanity. She continues to inspire us to push the boundaries of multidisciplinary learning and to apply our insights for the betterment of the society. The facts that people from all over the globe with the different timings have joined us today for the theme of the lecture series, Climate Change and Public Health, which itself tells the importance and the urgency which is required for this change. Climate change is no longer a distant or abstract concept. It's a tangible reality that affects every aspect of our life. In the first edition of the lecture series, we have been a witness to how climate change is intricately linked to the public health, rising temperature, altered precipitation patterns, so that it leads to rapid increase in infectious diseases. We are also aware of the impacts of the climate change on the degradation of our natural resources, including water, air. Various parts of the world, including ours, have affected by extreme weather events like floods, droughts. The psychological toll the climate change has to have produces in the society, like stress, anxiety, depression, and trauma from climate-related disasters, is a growing concern, and that requires immediate attention. As an institution of eminence, MAHE is dedicated to education, research, innovation, and community service. We have a pivotal role in addressing these challenges. The complexity of climate change demands an interdisciplinary collaborative approach and global partnership to combat the impacts of climate change on public health. I would like to express gratitude to Mr. D.A. Prasanna, Chief Patron PSPH, and Professor Rajani Prasanna, the guest of honor of the day, for the Endowment lecture series that is dedicated to offering an unprecedented opportunity for innovation, collaboration, and positive change to address one of the most significant challenges of our era. I consider it a privilege to formally inaugurate this event. By harnessing the collective expertise and passion within this room and beyond, I believe that we can develop solutions that safeguard our health and protect our planet. I wish the event and the endeavor a grand success. Thank you. Thank you for the opportunity.
Thank you, sir, and thank you for setting the scene and also providing the need for a multidisciplinary approach. Thank you very much, and thank you for the guidance. Let me now invite our guest of honor for today, Mr. Nihar Prasanna, whose family is also supporting the Endowment lecture series. Mr. Nihar Prasanna, over to you.
Thank you, Dr. Verghese, and good evening, good morning, distinguished guests, esteemed faculty members from MAHE and all partner institutions, dear students and friends. It is an honor to be here today on behalf of Professor Rajani Prasanna and to launch the second edition of her Endowment lecture series on climate change and public health. I believe it will serve, as the previous speaker said, as a platform to really engage in critical discussions on this important topic. The first edition of this series provided profound insights into the multifaceted impacts of climate change on public health, encompassing a wide plethora of themes, including extreme weather events, pollution, health impact assessments, carbon emissions, and even the role of indigenous art and culture addressing these challenges. Today, we will continue this dialogue, but also introduce new topics such as digital health and how they can intersect climate change to forge a path forward. Now, as climate change increasingly affects global health, it is essential that we harness the power of digital health technologies. Tools like weather and pollutant monitoring systems, along with real-time health monitoring, are pivotal to providing data that can predict and manage climate-related health issues ranging from vector-borne diseases like malaria and dengue to more respiratory conditions exacerbated by air pollution. For instance, integrating digital tools with early warning systems can alert communities about impending health risks, enabling timely interventions and potentially saving lives. Beyond immediate health impacts, climate change also poses long-term challenges to public health systems, particularly in low and middle-income countries where resources tend to be limited. Here, digital solutions can be game changers. For example, mobile health applications can track and manage the spread of infectious diseases that are sensitive to climate variables, ensuring that health authorities are better equipped to respond to potential outbreaks. The convergence of digital health and climate change is not just about technology, but also about strategy. Health impact assessments incorporating climate data can provide a comprehensive understanding of how our environment changes health outcomes. This integration allows for more effective policymaking, ensuring that health interventions are designed with climate resilience in mind. Moreover, advanced climate monitoring tools such as satellite-based systems, IoT-enabled sensors are crucial in tracking carbon emissions and environmental changes. These tools not only help in reducing emissions, but also offer a more cost-effective approach to monitoring and adapting to climate impacts. In the long term, such investments could be more economical than addressing the health and economic burdens of climate inaction. As we look ahead, it is clear that our response to climate change must be multifaceted, combining technology, policy, and community engagement. We must prioritize adaptive strategies that enhance the resilience of our health systems and communities. This includes strengthening global collaborations to share data, best practices, fostering innovation in climate financing, and promoting sustainable practices that reduce our carbon footprint. Now, as we navigate the complexities of climate change, I believe that this lecture series will bring together collaboration, innovation, and unwavering commitment, enabling us to combat the challenges of climate change. It's an honor to be here again, and thank you all for joining, and back to you, Dr. Verghese.
Thank you, Mr. Niha Prasanna, and thank you for your continued support and encouragement, and we also give our respects and thanks to Professor Rajani Prasanna as well. Friends and colleagues, now we get into the meat of the matter. We are going to go into the presentations and the lecture series today. So I'm very pleased to have Dr. Vikas Kapil, whom I have already introduced as the moderator for today's sessions. So with great pleasure, let me invite Dr. Vikas Kapil to take over and run the rest of the proceedings for today. Over to Dr. Vikas Kapil.
Thank you so much, Dr. Verghese. It's my pleasure to be here. I want to thank you and the rest of the organizers for inviting me. I think that you and Dr. Rao and Mr. Prasanna in your opening remarks have really hit on some of the key issues that this lecture series and the session today are really all about. We're going to hear from four remarkable individuals in the next few minutes. And then hopefully after that, we will have some time for some questions and answers. Climate change, from my perspective, coming from a public health background, is probably one of the most multi-sectoral, interdisciplinary challenges that we face as a world going forward, not just in health and public health, but in so many other facets and aspects that we deal with when we talk about the changing climate, but particularly for our purposes in health. So today, one of the areas that we're going to explore with the initial remarks from Dr. Henry Falk, then Dr. Tom Matei, Professor Srikanth, Dr. Jayaram. We're going to touch on an issue related to the interface of climate change and health, related to policy and governance and how systems approach some of the challenges related to climate and its impacts on health. So what I would like to do without further ado is turn over to the speakers. We will do their presentations. Please, as they present, please think of questions, topics for discussions. We should have at least 15 minutes or so at the end after the talks are presented for some interaction and some questions and answers. And then, of course, later, we hopefully will be able to provide you all with a readout of the discussions today. So I'm very, very excited to hear the presenters. And without further ado, what I would like to do is invite my good friend, Dr. Henry Falk, who's also here in Atlanta with me, who's the professor at Emory University, to give us a few opening remarks and an inaugural address. So Henry, if I could turn it over to you. And then following Dr. Falk, we will hear from Dr. Tom Matei next.
This is actually a very great privilege for me to be listed as chief guest. It was a real honor for me to be one of the speakers at the opening session for the first series of Professor Rajani Prasanna Endowed Lecture Series. And so it's just very wonderful feeling to be able to come back here for the opening of the second session. I would like to express my gratitude to Mr. D.A. Prasanna and Professor Rajani Prasanna. I've gotten to know Mr. D.A. Prasanna in recent years, and his leadership and commitment to the growth of the Prasanna School of Public Health is just very impressive to me, and I think augurs very well for the future. And certainly, I think this endowed lecture series has been a very innovative and thoughtful approach to addressing the issues of climate change. And so I'm very happy to be able to participate in this process. I also wanted to thank Rahul Clare and Dr. Asher Kamath and all of the staff who have worked on setting up this very important lecture series, and also their work on the publication for the first volume and hopefully publication of this series of lectures as well. And I also wanted to extend my welcome to Professor Dr. Sherian Varghese as the new dean of the Prasanna School of Public Health. He brings an enormous amount of experience and knowledge of public health broadly, and I think this is just a very wonderful opportunity for the school, and I extend my welcome to him. So we have three very important talks today, and I just wanted to provide a brief introduction to them. The first talk by Dr. Matei is related to the cities and the role of cities in the climate change issue. You know, in the early part of the 1900s, only a small fraction of the world's population actually lived in cities, maybe only 10%. We are now closing into maybe 50% of the world's population living in cities, and the projections are that by 2050, it may be 70%. So the future of interaction of the world's population with the climate change problem will reside in cities. So I think Dr. Matei's role in working on the New York City effort to planning for working on climate change and the presentation he will make this morning is very important and hopefully will be very valuable in thinking about the future of Indian cities and others elsewhere as well. The second talk by Professor Dr. Srikanth is also very critical. You know, there is so much thought about how climate change may impact and actually accentuate the existing problems that we have with issues like vehicular emissions and air pollution. And so as we approach the impact of climate change, it's very important to really explore these issues in great detail. And I very much look forward to Dr. Srikanth's presentation. Finally, for Dr. Jayaram's presentation, you know, environmental health is a very challenging area because the health people do not control the issue. They provide important input, guidance, and so on, but we must work with environmental ministries and agencies, energy, trade, and others. And so the governance of environmental health issues is very complex and very important. As we saw in the COVID-19 pandemic, for very large issues, the governance gets very complex. And I think for climate change, it will be yet more complex. So I very much look forward to Dr. Jayaram's presentation on health governance and global warming. So with that, I'm happy to turn this over to Dr. Mate, who is a very old friend and colleague from his time at CDC and certainly since.
Thank you, Henry. Thank you, Vic. Thank you for all the organizers. I'm really honored to be here, honestly. I was last in India in January 2020 when the pandemic was looming. So it's great to be in 2D, connecting with people in India and with my friends and colleagues from CDC, Henry and Vic. This photo was taken at a chess tournament, a little neighborhood chess tournament in Central Park that I walked past recently. And I'm not a good chess player, but what I know about chess is that it's important to think some moves ahead, but also important to guard against vulnerability to being checkmated in the next move or two. And that idea is one of the things I want to address in my remarks this morning. I hope they're relevant. I'm going to be talking very specifically about New York City mainly. I'm going to share briefly a framework for how to think about public health engagement in local climate action. I'm going to use the example of heat and health in New York City, and also talk about the New York City Panel on Climate Change, the fourth assessment. I was honored to be a member of the fourth panel on climate change, which just wrapped up its work this spring. And then very briefly at the end, I'm going to share a few thoughts on a global urban perspective, touching on the issue that Henry mentioned, which is the importance of urbanization. There are many people I could acknowledge whose ideas contributed to the ones I'll be sharing. As far as the climate change panel goes, I want to make clear I'm representing my own views and curated examples from that assessment rather than representing the panel. So how do the roles and skills and tools of public health map onto the different concepts in local climate action? Well, to me, it starts with bread and butter public health activities of surveillance, research, and public communication. For adaptation, it's important that public health institutions, the public health sector, be characterizing the recent and current weather impacts on health. And in doing that, identifying vulnerable populations, settings, and places. For mitigation, it's critical that public health be identifying not only the health co-benefits of mitigation activities, but potential harms if mitigation activities are not mindful of factors like how they might impact on physical activity, on energy costs and reliability, and on air quality. To quantify these co-benefits and harms where possible. Equity, at least as long as I've been working in public health, the words we've used have changed from health disparities and others, but advancing equity has always been a core value of public health. And so when we think about vulnerability and impacts, and when we summarize data, we need to be characterizing the distribution of the impacts and vulnerability according to different measures of social advantage and disadvantage, and advancing solutions that protect vulnerable, marginalized groups. Then, as Henry mentioned, working across sectors is very important. At least in New York City, the clinical care delivery, some of it resides in public health agencies, but mostly it does not. So working with public health, working with the clinical care community, providing evidence-based prevention and health promotion information is critical because a healthier population will be more resilient and adapted to climate change. Then sharing preparedness education so that providers and their patients know what to do to prepare for different types of climate risks. Collaborating on surveillance has already been mentioned. And then very important and difficult to do, but critical, I believe, is collaborating with non-health sectors like housing, energy, transportation, other lifeline infrastructure sectors, land use, parks, and environmental conservation. And we need to share public health evidence to inform those policies. And very important is the concept of maladaptation. Perhaps people listening are already familiar with this, but I'm just going to read what the IPCC, how it defines maladaptation. Maladaptive responses to climate change create lock-ins of vulnerability, exposure, and risks that are difficult and expensive to change and exacerbate existing inequality. Maladaptation can be avoided by flexible, multi-sectoral, inclusive, and long-term planning and implementation of adaptation actions with benefits to many sectors. So just taking the example of heat and health in New York City, I first got involved in working on this issue about 18 years ago during a severe heat wave or following a severe heat wave in New York City in 2006. So among the tasks that the health department, partnering with academic institutions, undertook is answering basic questions. How does the risk of death from caused by heat vary with the weather? And we learned that the threshold for issuing heat warnings and heat emergencies in New York City was too high. We're not as adapted to hot weather as cities like Atlanta, where the CDC is, for example. We asked who is vulnerable and in what settings, and that identified that exposure at home in New York City is extremely important, and in that setting, a lack of air conditioning is the most important risk factor for dying or getting seriously ill during hot weather. Air conditioning is inequitably distributed in New York City, although it's virtually ubiquitous in our commercial buildings and residences. We asked, what do people believe? What do they see in the news and do when hot weather is forecast? And we learned that most vulnerable people stay home, even if they can't stay cool. The health department, the climate and health team, has improved on the surveillance of heat-related mortality over time and now issue an annual legally mandated heat mortality report. What they showed in the most recent report is that in New York City, as in the country, from about 1970 through the 2000s, mortality associated with hot weather decreased quite dramatically. But in the last decade or so, there's been an increase in heat-related mortality in New York City. And very important, they've learned that most of the excess mortality associated with hot weather does not occur on extreme days. It occurs on the non-extreme days, which are much more frequent, even though the risk is lower on those days. So an implication of that is we can't just rely on emergency responses and things like cooling centers to protect vulnerable people in New York City from hot weather. The health department also undertook research and collaborated with a postdoctoral fellow at Columbia University to develop a pretty unique heat vulnerability index, which is really calibrated to factors that are associated with greater increases in mortality during hot weather. And what's been learned is that both environmental and social factors matter. So the racial and ethnic composition of neighborhoods, the median income, the surface temperature, the amount of green space, and very importantly, the proportion of homes with air conditioning matter to how vulnerable neighborhoods are to hot weather. If you're at all familiar with New York City, or even if you're not, I can just tell you that the darker, higher risk colored neighborhoods are places like in the South Bronx, in northern Manhattan, parts of Queens and Brooklyn that are neighborhoods that are often characterized by low income, high proportion of African American and Hispanic populations, and basically places where social disadvantage concentrates in the city. Another important function of public health, and one of the dividends of what the health department and others have learned about hot weather and health in New York City, came when the COVID-19 pandemic complicated the city's usual strategy for dealing with heat waves. So it made it difficult and potentially dangerous to have vulnerable people gathering in cooling centers. It was also the case, even though it's been known for a long time that there's a very inequitable distribution of air conditioning, and that air conditioning affordability to pay the electric bill is a real challenge, that there were still big disparities in access. So the city launched rapidly a program to distribute air conditioners to low-income seniors, and the health department worked with academic partners to launch an evaluation of that effort, which is summarized here, showing that the distribution of air conditioning was successfully targeted to the higher risk neighborhoods identified by the Heat Vulnerability Index. There was a larger effort to respond to this compound risk, which included emergency utility rate relief, and also creating a large number of open car-free streets. So people had places to go outdoors in shaded locations to socialize and get out of apartments that might have been too hot to be comfortable or safe. So if we think of the different timescales for dangerously hot weather in New York City, starting over on the right, we can think of extreme heat, when what's really a non-linear relationship of heat and mortality really gets very high. And that's when emergency warnings and responses like cooling centers are things that have been done for a long time in New York. And that's really where public health has often focused its efforts. But the data tell us that we have to do more than that. So for seasonal hot weather, providers need to be counseling patients at the beginning of the heat season about what they need to do to keep themselves safe. Air conditioning subsidies are another measure that is needed for addressing the seasonal risks of hot weather. And then longer term, public health evidence can inform how the environment is adapted to the heat, including things like tree planting for urban heat island mitigation, changing building design, enhancing social services and outreach to vulnerable people, and improving population health. Preventing diseases like diabetes, COPD, for example, makes the population less vulnerable to all sorts of climate risks. I mentioned health impact assessment. The health department on the left led a health impact study to look at how New York City's plan to reduce greenhouse gas emissions 80% by 2050 would have health co-benefits mediated through improvements in air quality. And they looked at how these benefits would be distributed in the population characterized by neighborhood income, and found that the benefits would accrue mostly to the less affluent parts of the city, the disadvantaged parts of the city. So air quality is one important co-benefit to consider, but it's long been clear that there's a problem with having too much focus on air pollution and in regards to transportation to avoid what I might call tailpipe tunnel vision. So an article that was published shortly after the diesel emissions scandal, cheating scandal broke, was cautioning that just switching to electric vehicles was not really a comprehensive public health solution to the harms caused by transportation, and that what's called a city model, which includes better public transport, better infrastructure for active mobility like cycling and walking, would have multiple and much greater health benefits. The New York City Panel on Climate Change, which I mentioned at the outset, is mandated in New York by a 2012 local law. The role of the panel is to advise the city on climate projections and how to adapt. It's a 20-member multidisciplinary panel, but the effort also involves recruiting other experts to contribute as reviewers and co-authors in the published assessment. In 2024, the fourth assessment was released. It included chapters on climate science, equity, flooding, a new chapter on futures and transitions. Health was a part of this assessment for the first time since 2015. A new chapter on energy and energy insecurity, which also grew out of work of the health working group that I was part of. All of the chapters and summaries in the past reports can be assessed at the URL climateassessment.nyc. And so I'm just really going to touch briefly on what's a very long, detailed set of assessments. The health chapter framework is shown on the right. Climate risks at the top, warming temperatures, sea level rise, precipitation extremes lead to exposures, which comprise the chapter sections in the health chapter. And then down at the bottom are health outcomes. But I want to call your attention to the two gray bars on either side, which represent factors that drive vulnerability in New York City. So these represent not only the population characteristics, such as their age and health, but also the physical environment. And we felt it was important to really center vulnerability in this assessment because these are factors that the city really has agency to influence, much more than the global climate, which is going to change no matter what New York City does. And really, even if emissions stopped globally tomorrow, we know that the climate will continue to change. For heat health impacts, there's a similar framework which focuses more on the factors that are relevant to heat, vulnerability factors that are relevant to heat, and similarly for flooding. In New York City, the two types of flooding that are most relevant for life safety are coastal flooding, storm surges that can drown people and destroy their dwellings. And more recently, we learned that pluvial or extreme rain flooding has the potential to be deadly in New York when the remnants of Hurricane Ida hit us in 2021. There are multiple phases of flooding events that impact public health. So even before a flooding event hits, people can suffer health harm through the stress of relocation. And after a major flood event has passed through, long-term displacement when homes are permanently or seriously damaged causes other health consequences. We've also learned in New York City that the type of dwellings and where people live in relation to ground level is very important. People were flooded and drowned in basement apartments during the Hurricane Ida event. In the Futures and Transitions chapter, we address two topics that have to do with maladaptation, how to undo it and promote population health, or how to avoid it. One concerned the public right-of-way, which is basically a jargon term for streets and sidewalks, and how to repurpose the public right-of-way, reducing the amount of space devoted to parking and moving private motor vehicles to more beneficial uses and efficient uses, which will provide multiple health and equity benefits. We also looked at the issue of mechanical cooling and the concern that it's a maladaptive societal response. And in doing that, we tried to frame the issue in the New York City context and ask the question, is subsidizing residential air conditioning for low-income, vulnerable residents maladaptive? And I'm not going to provide the answer to that question or any other detail, but just will point you to the publications if you're curious about how the assessment addressed those. So finally, I want to say a few things about urbanization, which Henry mentioned is a very important factor. One thing that I've learned in recent years is that it's a bit misleading when we say that half the world's population live in cities, if by cities we mean large cities like New York City or Delhi or Mumbai. In fact, I grew up in what I thought was not a city, but it's considered urban. It's a suburb of New York City. And in fact, when we say the majority of the world lives in cities, what we really mean is the majority is urban. And that's important because these urban areas that are spreading out, small cities and towns, are growing rapidly. And those are places where there's a chance to shape urbanization in a more sustainable, climate adapted way. Another thing that I've often confronted in giving talks to students and others is there's an idea that urbanization is causing climate change, or it's bad for global health or for the climate. And actually, urbanization, I think of it as one of the most ancient energy efficiency measures, really. And it still is the case that depending on how cities are laid out and how people get around, it can be a very efficient way of having a modern lifestyle with lower per capita greenhouse gas emissions. Finally, the relationship between urban air quality and greenhouse gas emissions, the linkages are very complicated and they vary in different national settings. So the interventions have to be tailored to the local context. So on the left side here, I'm showing some conclusions of a study done by Annenberg and colleagues, where they were looking at metropolitan areas, not cities exactly, at the relationship between particulate matter attributable mortality and greenhouse gas emissions in 250 urban areas. They found that there's a tendency for, with increasing GDP, the consumption-based greenhouse gas emissions, that means like accounting for things that we in New York City, for example, purchase from other places, consumption-based greenhouse gas emissions rise even while PM 2.5 exposures fall. So there's a tendency for developed countries to address air quality with tailpipe emission controls. That's one reason. We've moved industry and power generation out of large cities in most developed high-income countries, but we're still producing, emitting greenhouse gases from outside the city. We've also outsourced much of our industrial pollution to countries with less stringent air quality regulations. And one factor they didn't note, but it's, I think, quite important, is that problems like diffuse inefficient combustion from household fuels, trash incineration, remain important sources of air pollution in low and middle income countries. So if we think about interventions to address air quality in London, for example, a high income country, a city in that country, they've implemented a low emission zone. London and most cities across the UK and high income countries have already replaced solid fuels for household energy with things like natural gas and electricity. And that's been an effective intervention for them. But Chowdhury and colleagues estimated that in India, if household air pollution, its contributions from solid fuel combustion to ambient air quality, if those emissions were completely mitigated, the Indian ambient air quality standard could be achieved by that intervention alone. I do have one, this is a complicated and busy slide, but basically what it shows is that there's a wide difference among both high-income countries and between high-income countries and middle and low-income countries in per capita energy use. But if you look at the right, the graph on the right, healthy life expectancy, One of the things that stands out to me is that the United States is and has been for a long time lagging in life expectancy, even though it's a high outlier in energy use per capita. And so that raises some interesting questions about why that is and what it means for mitigation, for reducing energy consumption in ways that might actually improve health in the United States to allow energy consumption to grow in places like India and other low and middle income countries. I've covered a lot, I know, and I've added at the end of my slides, which I'm happy to share, a number of links to publications that my remarks are based on. And I want to, again, thank you for inviting me. This quote from an article in the Planetary Health Journal is something that I believe strongly, is that cities and all sorts of human settlements are for people. And if we're not centering human health, well-being, safety, and security, and economic opportunity as central considerations in sustainable urban development, I don't believe we'll succeed in protecting the planet, and public health will suffer. So thank you very much, and I hope I have time later on in the discussion to respond to questions.
Thank you so much, Dr. Mate. Really wonderful presentation. Really some stunning data on the relationship between heat and heat-related impacts and vulnerabilities and societal inequity, even in New York City. So, and let's go to our next speaker, Dr. Srikanth. I think Dr. Mate's talk may actually be a nice segue to your remarks on the way forward to reducing vehicular emissions to mitigate climate change and enhancing respiratory health with a focus on India. So Dr. Srikanth, may I turn it over to you now? Thank you.
So thanks, organizers, for inviting us, and I'm accompanied by my co-author, Dr. Lavanya, who was just on her PhD in this area. So one of the things that we want to basically say is that the contribution of road transport to global CO2 emissions varies from country to country. Obviously, the developed countries and the countries which are part of the Annex 1 to the Rio Convention, they have got very high contributions from road transport to CO2 because they are very much dependent on private transport, particularly cars. To give a number, basically in India, we have about 35 cars per 1,000 people. So, and you know, in US and Europe, basically it's more than 500 cars per 1,000 persons. So therefore, our contribution of road transport in India is lesser. But of course, basically the contribution of energy is higher because we are a coal-dependent country. In this particular talk, I am focusing more on urban air pollution and what are the contribution. What can be done to mitigate urban air pollution, and also how is it linked to CO2 emissions. Actually happening in India is that there has been a sort of explosion in the number of private vehicles, unfortunately. What has happened over the last 30-40 years is that actually more and more people, it is connected with obviously the increase in per capita income and people's aspirations. The number of vehicles actually you can see is actually exploding in the last 20 years. And unfortunately, in urban areas, India is also rapidly urbanizing as many other countries. But the problem basically is road space has actually not increased to the same extent. So therefore, what has actually happened is that vehicles are now starting to contribute 20 to 30% of the total PM 2.5 emission inventory in cities. This is an average across cities, and it's in many cities it's much higher. So I will come to a particular city which is one of the mega cities in the world, that is Bangalore, which is also like, you know, what is called the Silicon Valley of India. So what we have done basically in this is that actually we have done a multi-year study to basically measure the exposures of PM 2.5 in this city, because we do not have as many monitors that are actually required for a city of this size. We got so around 900 square kilometers is the area, but we don't have enough air pollution monitors. So we had to go with this geospatial modeling and use very standard methods to basically come with the high resolution maps. And The next thing which is very important and which is very much lacking in India is how is this connected to respiratory. There are a number of studies that have been done in US, in Europe, and also recently in China. The studies relating PM 2.5 and respiratory health in India are very, very few. A few studies are ongoing by Public Health Foundation of India. And I'm very happy to say that yes, okay, at my institution, the National Institute of Advanced Studies, we have actually done a very pioneering study to basically link, establish, quantify the relationship between PM 2.5 and respiratory health. And since this PM 2.5 pollution in cities like Bangalore is coming mostly from fossil fuel, which is coming from transport, so directly the mitigation measures for PM 2.5 pollution are also linked to the mitigation measures for climate change. So now I will turn over to my co-author who has actually done the study. So Lavanya, please go ahead.
Yeah, thank you, sir. So we have conducted 3 health studies that will link the PM 2.5 pollution in Bangalore to the respiratory health of people in Bangalore. The first study focuses on the childhood respiratory OPDs. This data was collected from the 5 major government hospitals in Bangalore. This data was collected from a municipal corporation. So what we have done here is based on the model 1 kilometer by 1 kilometer prediction for PM 2.5 concentration. So we have attributed this childhood respiratory disease OPDs, the number of visits to the PM 2.5 concentration for the entire Bangalore district. And we found that there is a relationship exists between PM 2.5 concentration in Bangalore and the childhood respiratory illnesses, that is the number of visits that is coming for the respiratory illnesses, and which the correlation is found to be 0.321, and this correlation is found to be statistically significant at 95% level. So the next study, because these are major government hospitals and people all over Bangalore come here, and even from outside Bangalore also come for these hospitals. It's very difficult to attribute the PM 2.5 concentration, which is over Bangalore, to the number of visits of the children coming to those hospitals. And therefore, we have moved on to the next study. We have focused on one particular hospital, and we focused on the emergency hospital visits for the respiratory illnesses. So this hospital is located in a place called Hebal, and the hospital name is Bangalore Baptist Hospital. So here, what is the logic behind this? Those people who are residing closer to the hospital will be going to this hospital for the emergency visits. So what we have done is we have attributed the PM 2.5 concentration around this hospital to the number of visits that is happening in that hospital. So there also we found a positive correlation between the PM 2.5 concentration and the total respiratory emergency visits, and as well as separately as lower respiratory tract infections and upper respiratory tract infections. The correlations found to be very high, and in addition they are very much statistically significant to 95 and 99% level in case of respiratory emergency visits. So again, here, since we are not taking into account of the other confounding parameters, which between PM 2.5 and the health effects, we have moved on to the third study. So which is, we have conducted a cross-sectional study in the length and breadth of Bangalore. We have selected some 17 nodal locations in Bangalore where the pollution monitoring stations are present, and 6 to 8 locations were selected around that based on the recce. And we have a structured questionnaire approved by our institute, and therefore we have gone ahead and we have collected enormous data, extensive data on demographic details, socioeconomic details, and the people's acute illness and chronic illness and travel information. We have collected an extensive information on those, and the end result of this study is that we were able to quantify the impact of PM 2.5 on the respiratory health of those people who we have surveyed. Since we have got the model built for 1 kilometer by 1 kilometer, we were able to attribute exactly the exposure of the people because we have got the information about them, about their residential location as well as their the work location, how much time they spent in the work location as well as in the residential location, how far it is, how long they take to reach there, and which mode of transport they use. And so the result of this work is to find out the odds ratio. So the odds ratio that we found is 1.38. It means for every 10 microgram per meter cube increase in VM 2.5 concentration in Bangalore, 38% there's an increase, the likely increase in respiratory illnesses. That's what we have come out. Basically, here we have actually quantified the relationship between PM 2.5 and respiratory illnesses, taking into account of all the confounding parameters between them. And one more result that we have come up with in this work is that lower and middle income households are more vulnerable to PM 2.5 related respiratory illnesses compared to the higher income households. So we have found that pollution is there, PM 2.5 pollution is there, and it has an impact on the public health. Yes. So yes, we have to curtail the PM 2.5 pollution. So then the question comes where to curtail it and how to curtail it. So there comes like to answer the question like where to curtail. There's another study in NIAS which was conducted. It was basically to find out the high resolution gridded emission inventory for PM 2.5. There we have found that 46% of the PM 2.5 pollution is due to the fossil fuels from the road transport and 12% from resuspension of the road dust, and 32% of PM10 is from road transport and 36% from resuspension of the road dust. It means that around 58% of PM 2.5 pollution and 68% of the PM10 pollution is around this vehicular exhaust, vehicular emissions. So there's something that is coming out that we have to reduce the vehicular traffic. So reducing vehicular traffic in cities is going to have a major impact in reducing the PM pollution in cities too. So how do we reduce? So there's another study which says that shifting the ridership from other modes of transport like buses, two-wheelers, cars, auto, etc. to metro, which is the public transport, is going to reduce a lot of PM pollutant emission, not only PM, CO, hydrocarbons and NOx. Especially, we have 3 scenarios for that, where we have, for the scenario 1, we had this affordable metro service with 1,000 meter of last mile, scenario 2 with 2,000 meter of last mile, and scenario 3 for 4,000 meter of last mile, where we found that 51 kg of PM will be reduced in scenario 2, scenario 1, and 90 kg per day in scenario 2, and 107 kg per day in scenario 3. So there is a huge reduction of PM emissions with a shift in ridership from other modes of transport to metro. In addition, we also found that shifting in ridership from two-wheelers to metro has a greater impact. For example, in scenario 1, there's a 43 tons per day of carbon dioxide emissions going to be curtailed when they're going to shift to metro. Similarly, for scenario 2 and scenario 3, to 78 tons per day and 89 tons per day, respectively. So we found that there is a huge impact while shifting the ridership from other modes to metro. In the end, we would like to say one thing is that by having accessible and affordable public transport, like example here metro, is going to reduce an air pollution in enormous amount, as well as it is going to mitigate climate change in cities, which in turn is going to have public health benefits too. So this is what we have come up with by putting together 3 studies and some useful results.
Wonderful. Thank you, Dr. Lavanya. And yes, thank you, Dr. Srikanth. Very interesting work. And I'm sure that in the discussion session, hopefully we will have some time, because some of the issues that you raised, I think, were also touched on in Dr. Mate's presentation. So without further ado, let's go to Dr. Jayaram. And Dr. Dhanasree, maybe your presentation will sort of bring this all together for us. The discussions on air pollution and sources and potential strategies for mitigation and adaptation, and then Dr. Mate's presentation on the New York experience and the climate assessment in New York City. So let me turn it over to you for your remarks on the alignment between global climate and health governance and what the priorities and challenges are. So thank you so much, and over to Dr. Jayaram.
Yeah, thank you so much, Dr. Kapil, for that introduction. And like you said, my expertise, or what my area of research is mostly on climate governance, and I think most of what I've learned about health is courtesy Prasanna School of Public Health and my engagement with the team that also worked on the first series of lectures under the Professor Rajani Prasanna Endowment lecture series that happened over the past couple of years. So a lot of my learning comes from that. So thank you so much to PSPH and the entire team for inviting me once again to the second series of lectures. And I'm very happy to be joining. My presentation is looking at a macro level. Of course, it does connect to the local level issues that were discussed in the previous two presentations. But as I look at it, I'm usually working mostly with institutions and politics, and especially at the international level. So my presentation will primarily look at what are the priorities that have been set so far in the global climate governance agenda, as well as the global health governance agenda, and what are the challenges and what opportunities lie ahead. And I think a lot of solutions and opportunities that were also discussed by the previous two speakers, and also Henry, who also mentioned some of it. And I think this is an important part of where the global agenda on health governance and climate governance will also move ahead. So where it comes from, I think, of course, especially with last year's COP and in Dubai, for the first time having a declaration or an agreement on climate and health. Of course, a recognition of this came way before, but this particularly sort of highlighted the fact that how much climate and health governance agendas may be aligned with each other. But we also know that a lot of it is still in the making, and there is still a lot of gap in terms of implementation, and also even in terms of design and planning of these policies and governance agenda. To start with, I think for me, it's also important to delineate what I mean by global climate governance and global health governance before going into the main parts of how these issues are interlinked with each other. And of course, this sort of brings together the experiences of cities like Bangalore and New York and various other cities that have also implemented their own climate change action plans and health and climate action plans, as has also been seen in the case of many cities. The climate governance space is primarily, we are looking at the UN Framework Convention on Climate Change. And of course, we have the Paris Agreement in place since 2015. Whereas the global health governance, we look at the larger institutional mechanisms, including the World Health Organization, the international health regulations, and the global health security agenda itself. So within this space, you can see that largely there is a recognition of health as a climate change issue, or, for that matter, by the health governance institutions also, that climate change is an integral part of the global health governance agenda as well. There is a lot of alignment in terms of how climate adaptation could help adapt not just communities but also health systems to climate change. But also there is increasing awareness of the fact that greening health systems or public health systems could also be something that also adds to climate mitigation goals of countries, particularly as they institutionalize their nationally determined contributions and other policies at the national level. So in that sense, there is a lot of commonalities, and especially this comes from the fact that there are co-benefits of climate and health policies, right? So a lot of examples that were also mentioned by the previous speakers shows that whether it is dealing with vehicular pollution or, for instance, looking at, climate adaptation practices without, with the caveat that some policies could also lead to maladaptation, health policies could also lead to maladaptation, particularly with the uncertainty that exists in the scientific or even social factors that contribute to the uncertainty. But the larger understanding is that there are co-benefits of climate and health policies which can help us guide through this process of aligning them. So as we speak, we have so many different international frameworks in place, and all of them have references to climate and health. So it's not just the Paris Agreement or the right to environment, the right to good environment, or the fact that there are also like Sendai framework for disaster risk reduction, the Sustainable Development Goals agenda. All of them have these interconnected goals that are associated with them. Just to briefly sort of say where did it all come from? So WHO and climate change, WHO, of course, this is not something new. There has been an early recognition of it, particularly in the 1990s, with references to like vector-borne diseases, malnutrition, mortality from extreme weather events, which led to a sort of a broader sort of agenda on how WHO can deal with the climate issue or the climate crisis as it is increasingly sort of also acknowledging it as. So some of the ways in which it can contribute to climate action, as it says, is through advocacy, collaborations, monitoring, capacity building. And this is something that has come a long way since the first resolution in 1998, and then the 2008 resolution, which did come up with a collective action sort of plan on climate change and health. And since the 2009, 5-year work plan, the One Health approach particularly is something that is bringing in the climate aspects more and more into the health agenda at the international level. The WHO is obviously becoming more and more active. Now, this is from my own experience of, working on climate governance and global climate governance. You can see that WHO has been actively lobbying for the inclusion of health in climate discussions because, there seems to be this kind of convergence in terms of interest in, funding and also policy alignments on other issues. With the launch of the climate change and health country profiles in 2015, there was a lot of, the need for recognition of these interconnections also help sort of feed into the, whatever work programs and the technical advisories or the kind of innovation that we need started to be also recognized within both UNFCCC as well as the WHO. And of course, I think the latest sort of addition to this is the WHO. It is a draft still, the pandemic agreement, which, to be honest, like if you see the way it has moved, you can see that the climate references to climate has become minimal. I think it's only just once that climate is mentioned. So as we see more and more dilution of it in the pandemic agreement, you can also see that even though there is so much recognition of it, there is still a long way to go in terms of alignment between policies and institutions that work on these issues at the international level. The UNFCCC and how it has been dealing with health. And I think, again, starting with the scientific aspect, of course, the IPCC 6th assessment report has also clearly stated the grave health impacts of climate change. And but however, if you look at the overall assessment of how health is treated within the space, the UNFCCC mentions health only twice. The Paris Agreement mentions it once, and it's only in the preamble. So pretty much there is still a long way to go, even when it comes to the alignment of, climate, global climate governance with the health imperatives. Now, one of the things that I already said earlier that, COP28, yes, did dedicate a health day and a ministerial on climate and health. And there was also a health pavilion, which was something that was seen as a landmark development. But the fact is, I think this is something, this is something typical of UNFCCC process, that you see similar sort of declarations coming up every now and then you forget that this is not the first time this issue was discussed. And so COP28 was not the first time. COP22 had also a declaration on health, environment, and climate change signed, and there was also a key thematic. It was also recognized as a key thematic area in the Nairobi Work Program, which was primarily targeted at least developed countries, small island developing states, etc. So the entire the focus that was on this health day in COP28 and the declaration that was also signed over there, it is endorsed by 123 countries, looking at improving health systems, resilience to climate impacts, reducing carbon emissions, and fostering collaboration on global health issues. This is not the first time a declaration has actually come out. But as you can see, it's again non-binding in nature. And some countries, including India for that matter, has not really signed this declaration for various reasons. One of them being that the second point here, especially reducing carbon emissions in the healthcare system, could imperil India's own efforts to provide universal kind of healthcare within the country. There are a host of other agencies, UN agencies, including, for instance, the 2021 Human Rights Council, how it formally endorsed the right to a healthy environment, also talking about sort of a One Health approach, combining health and climate issues. There are numerous regional organizations, including, some of them work directly with the WHO, including like the Pan American Health Organization, or the European Environment and Health Process. They, have these integrated policies looking at air quality, sustainable development, and climate change. African Union, for instance, looks specifically at a resilient development strategy with both health and climate, which is more targeted at issues that are faced within the continent, including like climate impacts like droughts and food insecurity. And Southeast Asian nations, as ASEAN, for instance, has a climate and health work plan. Pacific Island also has a health officers association that is looking at building climate resilient health systems to address the unique sort of challenges of the Pacific Island states, which includes like rising sea levels and so on. Now, what are the challenges? So you can, it's very clear that there is a lot of institutional fragmentation, that there are different institutions working in silos, looking at these concerns, and because of which there are also funding gaps. And there is a lack of, legal commitments and accountability. So there is not much of monitoring or assessment of how the declarations, for instance, that have come out of the UNFCCC, or, the kind of commitments that have been made under the UNFCCC related to health are not really being monitored in any way. So that is something that raises questions about the accountability. There is also an issue with, the data and knowledge integration that, so the data that is provided, say by, or the knowledge that is generated within one particular institutional mechanism may not be really feeding into other mechanisms. So there is problems with that as well. Largely, political interests, and also the fact that these institutions have been looking at climate and health interlinkages in a very reactive way, like the COVID pandemic sort of, woke up everyone that, we need to discuss environmental health in a much deeper manner. Yet, the kind of reactive sort of approach to these issues is a big challenge in terms of, also looking at more alignment between the two spaces. Now, my last slide is about opportunities. And of course, there are plenty of opportunities at the global level, particularly if you look at the UNFCCC, and the Paris Agreement has a mechanism called the global stocktake. And this is one of the means through which more and more issues are being integrated into the like last year, the year before was gender, and, now you have health. So these kind of efforts is something that is also happening through updated NDCs. More and more countries are now mentioning NDCs. I remember that initially the nationally determined contributions of many states did not even mention health. Even if they did mention health, it was, in a very it was not really explicit in many ways. And also there was hardly, one or two countries that also had specific sectors that were associated with the health and climate nexus, some mentioning energy or some mentioning, the waste management sector or waste generation sector. So there were very few countries that really recognized them sectorally and also in terms of the need for assessment and monitoring. However, as I said, the health impacts themselves have largely been recognized. There is scope for, of course, collaborative global research agendas. There is, science-based policies wherein, of course, we need to bring in other issues, including biodiversity, and desertification, and so many other issues which are also linked with them. Early warning systems, innovations and cross-sectoral sort of governance platforms and health risk assessments. All these are, increasingly there is interest in carrying them out at a, very international and transnational level, but there is more scope for that. I also have, seen how global renewable energy alliances like the International Solar Alliance is increasingly looking at greening healthcare systems. And of course, this goes also with the fact that there are many countries where decentralized healthcare systems, solarized healthcare systems are also helping, with this expansion of access to healthcare in the most, remote and even inaccessible areas in many ways. And there is scope for leveraging health funding for climate resilience and also climate funds, like the Green Climate Fund or the Global Environmental Facility, for also creating sort of, that space for health adaptation and sustainable health systems. And from a Global South perspective, and I think this is where, the disproportionate effects, which was also spoken about by the other speakers, is something that needs to be also integrated into understanding how climate justice needs to be, kind of operationalized in policy and governance spaces. So yeah, I think I will stop there. Thank you so much for your patient listening.
Thank you so much, Dr. Jayaram. Very nice presentation. I think it's a good global overview, and hopefully for our audience, it also connects the global perspective with what's happening locally in India and in the region. And I think it's very, it's sort of an inspiring, it's sort of inspirational when we think about some of the issues that were discussed by the other speakers and how those are relevant to not only India, but also globally. Dr. Falk, we have a few minutes. Would you like to share the slide that you wanted to present earlier? And then we'll go to a couple of the questions that are in the chat.
Sure, thank you.
Sure.
Rahul, if you could share the slide. I wanted to congratulate the three speakers. I think this is a wonderful start to the second series of the Professor Rajani Prasanna Endowment lecture series. I just wanted to highlight the importance of this lecture series and the value of the emphasis on climate change at Prasanna School of Public Health and in MAHE. So this is a climate risk index that evaluates risks for countries all over the world. It's done by German Watch, a group in Germany. And the climate risk is based on data from the previous 20 years. This is the most recent output from German Watch. And it's based on factors such as human impact, fatalities from weather-related climate change events, cost of those events, the frequency of those events. And I think, as you can see, India is right central in the epicenter almost of this arc that goes across South Asia and Southeast Asia, which is probably, the part of the world, suggested by this climate risk index as most heavily impacted so far, and presumably may be as well in the future. So just wanted to provide this kind of corroboration impetus to the value of what everybody is doing here, and I look forward to the remainder of the lectures in this series and the continued work of Prasanna School of Public Health and MAHE in this area, which is, I think, centrally important to India. Thank you.
Thank you very much, Dr. Falk. That's a wonderful slide and very relevant for today's presenters and also for the discussion. So we do have just a few minutes remaining. We had a few questions in the chat. Dr. Rahul's question was about the choice of modeling approaches. This was directed to Professor Srikanth, and Dr. Lavanya was about the choice of modeling approaches and whether machine learning approaches were employed in addressing the objectives. And I think that there's a nice explanation for that from Dr. Lavanya and Professor Srikanth in the chat, including a link to their publication. So I would direct folks to that. There was also a question about the possibility or challenges to conducting similar studies in smaller cities, and I think that also has been addressed in the chat, that the major bottleneck would be the availability of data on PM data and health data. There is a question for Dr. Matei. So Tom, I think one of the issues that came up was related to, whoops, looks like we may have lost that question. No, there it is. What would you see as sort of the takeaways? You talked about heat, for example, and the use of cooling centers and kinds of interventions for sort of climate-related emergency events. What do you think would some of the important takeaways and challenges that you foresee in implementing those types of strategies for countries like India or other low and middle income countries? Would you want to take a stab at that?
I think one of the challenges is having the right balance between responding to emergencies and making sure that we're attending to the other sectoral policies that will continue to either make the risk greater or less. So, there are examples in New York City. We discovered that we had a risk from flooding that was going up. Our vulnerability was going up because of the housing shortage, the shortage of affordable housing in New York, and zoning and permitting policies that were sort of looking the other way as people were living in unpermitted basement dwellings. So just as a general point, I would say a risk is that we get too focused on either the emergencies and we also, from my perspective, housing policy is climate policy. If we think at a very basic level, I don't know about everyone on this webinar, but I know I can depend on the apartment I live in to protect me and my wife from the vast majority of weather conditions we encounter. And protecting public health from climate is a lot of it is about housing policy. And so just while I have a chance to say a pitfall, since we were hearing about transportation and air quality and carbon emissions, I've worked on air pollution, not on physical activity and health, but I'm persuaded by looking at the large body of evidence, the biggest harm to public health from an over-reliance on private motorized transport is it increases the sedentary lifestyles and the metabolic and other physical health problems that go with that. And that's a big reason why the US has not only much higher energy consumption per capita, but we've had a long-running obesity epidemic, and our health lags behind that of countries that have done a better job of having a balanced transportation system. So I would say in a place like India, where there's this appeal of having your own vehicle. I understand it, but it's something that if we don't recognize that even for the drivers, for the car owners, for people who feel that they can afford it, it's actually, especially in urban areas, it is not an efficient or healthy or economical way to get around. And we keep having to kind of relearn that lesson and try to push back against it in the US. So that would be something I would want to highlight in thinking about public health and climate and urbanization in India.
Excellent point, Tom. And I think that was also highlighted in Professor Srikanth and Dr. Lavania's presentation about that sort of the consumer behavior and the last mile or the last kilometer connectivity for people and the impact of that on how people use mass transit, for example. So excellent point. We're very short on time, but Dr. Dhanasree, maybe I could ask you just in a minute if you could elaborate on the role of citizen engagement and also a few words on the co-benefits aspects. I see a number of other questions in the chat. We may not be able to get to those.
Very quickly, co-benefits, it means that a policy could have benefits in multiple sectors. Like, for instance, when you one of the cliche sort of examples that is given when you switch to cleaner fuels, for instance, say in the households, it does help with climate mitigation, reducing emissions. It also helps with better health benefits for specifically women. And therefore, it also has gender related benefits. There are other examples that I mentioned about the solarized health infrastructure that also helps especially those parts which are not connected with the grid will then have access to electricity and therefore better healthcare facilities. So that's what co-benefits means, helping different sectors. I mean, I think that's about that. But about citizen engagement, I think somebody else would be better, maybe at the city level, and maybe research networks, including the work that is going on, and what Matt mentioned about his team. These are all, I think, based on multi-stakeholder engagement. So I don't think these will provide a lot more sort of information, knowledge, and also means of implementation at all levels. So yeah.
Dr. Lavania, do you have any, or Professor Srikanth, any thoughts on Dr. Mate's comment on mass transit, for example, in places like India?
No, I think Dr. Mate really summarized what we just wanted to say also. And what we have done in our study is to basically quantify the benefits. Because what has happened in India is, while the metro authority is an independent authority, they do not bother much about the first mile, last mile access, and therefore the metro services are not reaching all parts of the city, particularly where the underprivileged sections of the society live, and that is actually robbing them of multiple opportunities for social mobility, economic mobility. And also what happens is that more and more people use private transport because they have to make multiple switches. So what is basically taken for granted in cities like London or Paris, etc., I think is something that is much lacking in India. That is having a uniform transport authority throughout the city to basically coordinate the fares, the tickets. These are all things that have been done and dusted and proven their utilization. What we have just advocated here is that this is now becoming very, very important in India, and this is much more important than subsidizing electric vehicles. So we say we are a developing country, money is always short. So if you have a limited amount of money, focus it on increasing use of public transport rather than subsidizing electric vehicles.
Wonderful. Well, I think that's a great place to end today's session. It's a very important take-home message for all of us, and I think all of the speakers, all of the presenters would enthusiastically support and agree to that statement. So without further ado, I would like to very much thank the organizers, Dr. Varghese, Dr. Rao, Mr. Prasanna, the presenters, and of course our audience members, and for all of your participation and your attendance. This is the first in the series. We hope to have many more opportunities to engage with you and to have further discussions like this. Finally, as Henry said earlier, I definitely want to thank the team at MAHE, Dr. Rahul, Dr. Asha, the entire team at PSPH that has put this program together. I thought it was very well organized, very nicely done. We thank you from the bottom of our hearts, and very much look forward to the future interaction and engagement. So Rahul, back over to you. Dr. Varghese, any closing remarks? We'll be looking for announcements about the next event.
Yes, sir. Thank you so much. Unfortunately, Dr. Varghese sir is on travel and right now is flying. Thank you so much, everyone. All the chief guests, Dr. Henry Falk, Dr. Ms. Nihar Prasanna, Dr. Kapil, Vikas sir, for organizing, for being such a support, and especially assisting us throughout. I'd also like to thank Dr. Tom Matt sir for being a part of us right now, and then also sharing so much insights, especially with your vast experience. And we had so much more questions, especially that two of the most important topics that were spoken to us was also by our very renowned colleague, Dr. Srikanth sir, whom unfortunately during my last two-time visit to Bangalore, unfortunately could not meet you. But also you can see that the world is quite small, because I think last time Dhanasree and Srikanth sir had met, and unfortunately I could not meet you. But then again, this also leaves us a lot of opportunity to see where can we all come together, work together. It could not be necessarily mean a huge big project. It could even mean just sharing through LinkedIn or small posts, or even a collaborative project. But thank you so much all for coming. I'd like to thank Dr. Vani Lakshmi madam over here for supporting us all the way. I'd like to thank Dr. Prakash Narayanan sir, professor, who's also Center Coordinator for Climate Change in One Health, and also Ms. Alisa, who's our research assistant. Thank you so much. We look forward to our next eventually. Thanks.